My second talk is on superficial radiation therapy. And I think the thoughts that you should have gotten this morning from Dr. Farberg's talk, Dr. Schlesinger's talk, is, we have a lot of ways of treating skin cancer these days. When I trained at NYU from 81 to 84, superficial radiation therapy was a big deal. Treated a lot of skin cancers with it, and then it really disappeared. It disappeared because there was no reliable manufacturer and the machines kept breaking down. I mean, even the radiation therapy machine we had at NYU back in the 80s, we almost held it together with tape. And so it leaked all the time. Heaven only knows what that did. So it disappeared. And then Mohs became sort of the way to treat people with, should have been just Mohs appropriate tumors, then all kinds of tumors. Superficial radiation therapy now has come back again because these machines are very stable now, and we have other ways of treating people. And like I said, I kind of get why none of us are using PD-1 inhibitors, but I suspect as we continue these talks over the course of the next years, more people are going to get more comfortable with the hedgehog inhibitors. They really do shrink down these tumors. But SRT is another way that we treat skin cancers, and I think there is a group that is appropriate for this. And so, we run a large Mohs unit, but we teach our fellows also SRT. I've done consultant work for Census. They're the major manufacturer of this device. In Florida. As I said, I have trained fellows, and I'm part of the consensus group on superficial radiation therapy. So, lots of ways of treating skin cancer. Superficial radiation therapy, to me, as someone who does a lot of laser work, and anybody who uses lasers for anything, it's just part of the electromagnetic spectrum. So it's simply one more wavelength. And this is very superficial radiation. This is not the stuff that's in hospitals. They're basically low-energy photon X-ray devices that operate at 50, 70, and 100 kilovolts, and what we choose usually has to do with how thick the tumor is or whether it's basal cell or squamous cell. It has a calibrated dose delivery system. It's got internal filtration technology. It is really simple to use. We have it in the office. Yes, it's a leaded room. We have a baby monitor so we can actually watch people when we treat them. To patients is no different than going to the dentist, having a lead drape put on them, and instead of the cone going in their mouth, x-raying their teeth, it's about less than a minute of x-ray going on the tumor. And the unit automatically stops when that dosage is delivered. So it's easy to administer. It effectively targets and treats lesions. It's gentle, indirect radiation. It only penetrates 5 millimeters in depth, which is why it's only for skin cancer. Has no impact on underlying tissue. Armin Cognetta really published the Sentinel article on this in 2012. So this has been around a decade already, looking at 1715 primary, non-aggressive, non-melanoma skin cancer. So that's the issue here. This is not meant for recurrences. This is not meant for morpheoform. This is not meant for skin cancers occurring in scars. Non-aggressive, primary, non-melanoma skin cancer, a cure rate which you could argue is almost as high as Mohs. And so the purpose of treating people is to eradicate tumor while maintaining or improving patient quality of life. This is in an area where cosmetically might be very sensitive, in an elderly patient who doesn't want surgery, on lower legs where surgery takes forever to heal. And although there are a variety of things that are treated, most commonly superficial radiation therapy by all of us is used to treat some, certainly not all, some basal cell and some squamous cell carcinoma. And it can be used virtually on any skin surface area. When we do it on lower legs, we tend to fractionate the dosage over a longer period of time because lower legs in older people don't tend to heal as well, but they still heal better than people who are having surgery. So cosmetic outcomes, scalp, eyelid, external ear canal and helix, nasal ala. Can I do any of these with Mohs surgery? Sure I can. But you have to think about this technique if you're thinking about cosmetic results. And you also have to get beyond the confusion that's out there between this, which is SRT, superficial radiation therapy, and the other kinds of radiation therapy most commonly done in hospitals, which are electron beam brachytherapy, electronic brachytherapy. The consensus group, which was formed a few years ago, which looked at all this, basically SRT, superficial radiation therapy, does have more energy and is deeper penetrating than Grenzray, which disappeared also. Grenzray was used to treat some patients with atopic dermatitis. It may still come back again. That was more superficial than this. Grenzray did not work on skin cancer. But brachytherapy, which is still commonly done in hospital settings, uses radioactive sources within or directly adjacent to the tumor. Electron beam therapy is used as a medical linear accelerator, which we would never have in the office. So electron beam therapy requires higher energy to encompass a superficial skin cancer because it's not meant to penetrate superficially, it's meant to go deeply. And with that, the corollary to that is superficial radiation therapy actually does have higher cure rates and better cosmetic results than these deeper versions because it is more superficially penetrating. It's certainly also much more cost effective in terms of the equipment and patient costs. So for large tumors, stereotype elderly Caucasian male with a large squamous cell carcinoma on the scalp. This clearly does present a simpler option than extensive surgery with whatever reconstruction may be required. And I tell people that maybe the risk of recurrence is a little bit higher, but it's not a lot. As I said before, SRT is certainly a potentially beneficial treatment for non-melanoma skin cancer on the lower extremities, but it certainly also has a favorable cosmetic result on the ala and the periorbital area. What about treatment margin? How do you know how much to treat? Well, the margins are based on previous data in literature based on surgery, not Mohs, but standard surgery. So typically, we do 8 to 10 millimeters beyond what we clinically see as basal cell carcinoma, 10 millimeters beyond what we clinically see for squamous cell carcinoma, although in fact, probably we don't need such large margins. That's what we tend to do. And the reason why we probably don't need such large margins is the beam and delivered dosage of superficial radiation therapy is a millimeter drop-off. That is, if you look at the lesion a millimeter from that, it's still very accurate. That's called the penumbra. And so therefore, the field probably doesn't have to be as large as we use for standard surgery. Initial measurement of the tumor size should be of the lesion and then maybe a couple of millimeters beyond that. And with that, almost all lesions for coding purposes are greater than 2 centimeters. So who are the ideal patients where I think about this all the time? I talked about this earlier. We're seeing more and more elderly patients, more and more complicated medical history patients. And so elderly, poor surgical candidates, they certainly don't have to stop their anticoagulants. Sometimes we even keep them on them for Mohs, but you know all the problems with that. Patients with poor circulation will do radiation therapy on their lower legs, will just fractionate it out over a longer period of time. People who can't do wound care, and people who have a significant fear of surgery or scarring, or as I call it, they have the Mohs burnout rate. They've had Mohs so many times they don't want any more surgery. There are very few contraindications. I mean, you can't do SRT right over a pacemaker, and no surprise, if they've had radiation therapy in the area before or any other scarring, you can't do that. So this is classic. This is a woman who didn't want to have surgery. We treat this a whole variety of methods, but we did it with superficial radiation therapy. There's the measurement of the lesion. That's the typical erythema you see after several treatments. That's about all they get. And then if you look on the bottom, you see 4 months post-treatment. Yes, there's a scar, but that's not the scar from the treatment. That's the scar from having the tumor. This is a large lesion on the chest. Again, measuring the size to be treated, kind of looking at it, going whatever, 8 millimeters or something beyond that. There's the delivery of the system. You see the lead drape. It's no different than what we all wear at the dentist. And here you can see what it looks like 4 weeks afterwards. So they get this flaking, redness, scaliness, but there really is no wound care. So this is somebody, and I think Aaron, maybe Todd mentioned this. This is somebody during my fellowship, 1985, I was like chomping at the bit to do Mohs on. I mean, wow, we love these large tumors. And Perry Robbins, who was my Mohs mentor, said to me, when you get to be 20 years later, you're not going to want to treat those people because they're a disaster, which they are. And so now we treat them with superficial radiation therapy, very easy to treat. And really the only hassle here is we typically treat them twice a week for 7 weeks, so it's 14 treatments. And so there's generally a family member who has to schlep them in. Some of you have heard this talk before, but those who haven't, I like talking about this lady. I have offices in New Jersey and in Midtown Manhattan. This is a lady who came into my office in Manhattan, I want to say 7 years ago. She was at the time a 42-year-old attorney, and she came into the office and she looked at me and she said, I know who you are. I'd never met her before. She said, I know you do Mohs. She said, I know you do superficial radiation therapy. And she said, I also know you're an attorney. And that was her starting point before I even got to say hello, okay, very aggressive. And I said, why are you here? She said, I'm telling you, you're going to do superficial radiation therapy on me, and I've spent my entire career suing doctors, so I'm telling you straight out. That's what she said. She said, and I will not sue you. I know you're going to tell me it's a slightly higher recurrence rate, but you're not cutting the side of my nose off. And she had seen several of my peers in New York, all of who are very good. Like Frank Sinatra said, if you can make it in New York, you can make it everywhere. These people are all very good Mohs surgeons. She did not want Mohs. And I did SRT on her, and she got no scar, and I've seen her years later now, and she's one of my biggest fans. And no, she did not sue me. So there she is. So we map it out, we protect her eyes, treat that small little area, and she had to come in twice a week for 7 weeks, and she did very well. And so we commonly use this on the nose for people who are concerned about cosmesis, which a lot of people are, who have primary, very well-defined basal cell carcinomas, and you can see this is before treatment, that's called simulation. After the 6 treatments, so for us that would be 3 weeks later. Some people do a little differently. And then 6 weeks after the final treatment. This is a guy that I'd done Mohs on for years who just had it. He said, no more Mohs, not having it. Squamous cell carcinoma, pretty well defined. Take about a 8-10 millimeter margin, treat him over the course of 7 weeks, and you can see the final result there. And again, more ears 6 weeks after that final treatment. And legs, and again, legs are just impossible to treat surgically. I have such a hard time getting these elderly people to heal. And some of them get wheeled in from nursing homes, and they have AIDS, and it's just impossible. And I have seen ulceration following superficial radiation therapy of the lower legs, but to lessen the likelihood, instead of doing this twice a week for 7 weeks, we may go out over 10 or 11 weeks, just make it so they heal a little bit better. 2 weeks after SRT, 4 weeks after, 2 months after squamous cell carcinoma left leg. So complications, they get some erythema, they get some flakiness, not any big deal. The erythema usually is related to the dose of radiation, so I talked about 50, 75, 100 kilovolts. We use the higher dosage generally in SCCs or deeper basal cell carcinoma. If you're going to treat darker skin types, and I'm not really going to talk about it, but we use this to treat keloids. It's probably the best way to treat keloids. They do hyperpigment. And occasionally you see a mild radiation dermatitis, nothing like what you see in a hospital setting. And we can treat them with silicone gels, lots of other things out there. There is insufficient evidence to support or refute any topical therapy for the prevention or even the management of these radiation-induced skin changes. I don't worry about them. They go away. Anti-inflammatory agents have no impact at all on this. And as I said, the management of radiation dermatitis, which is rare at best, is going to be based on the severity of the skin, and it's usually very mild. So here's an example of some radiation dermatitis. This is really rare. Use some silicone gel or whatever else you're using, and they tend to go away. Here's a reference that was put together by myself and that Armin Cognetta that I talked about, and our fellows as well, if you want to learn more about it. And these are the consensus guidelines that were published some 3 years ago. So we are running right on time.